Hello, thank you for joining us today. I'm Jeunesse Castonguay, VP at Clarius. I'd like to welcome you to today's live educational webinar as we welcome back renowned experts, Dr. Søren Boysen and Dr. Serge Chalhoub, for our first exclusively feline point-of-care ultrasound webinar. Today's topic is veterinary POCUS, diagnosing renal pelvic dilation. Is it the kidney's fault? Is it not the kidney's fault? Today, we're going to learn that it's not always the kidney's fault and how point-of-care ultrasound can help us assign blame. Using feline exams captured on video with Daisy, a large domestic short-haired cat, Drs. Boysen and Chalhoub will explain the role of POCUS in identifying renal pelvic dilation in cats. They'll demonstrate ultrasound techniques used to evaluate the kidneys at the right and left paralumbar sites, and they'll teach us how to narrow the differential diagnosis for renal pelvic dilation in cats. Before we start, I'd like to thank the Vet Show and NAFC for inviting all of you to join us here today. You're among 2,900 doctors of veterinary medicine who registered for today's popular event. This webinar is race approved, thanks to the Vet Show, so please do stay on for the full session to qualify for 1 CE CPD credit. By participating for 50 minutes or longer, you'll receive an email from the Vet Show in the coming week to redeem your educational credit. After the main presentation, we'll see live scanning with sonographer and clinical manager Shelley Gunther and our furry supporting character, Mayugan, a one-eyed, long-haired domestic cat. At any time during this webinar, you can use the Q&A box. Drs. Boysen and Chalhoub will be available to answer questions during the live Q&A session following the presentation. Let me now introduce you to your host. Dr. Frankel is trained in emergency medicine in California. A passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He practices in a busy academic teaching hospital in Vancouver as an emergency physician and serves as chairman of our medical advisory board. Hi, Dr. Frankel, and welcome back.
Hi, Jeunesse. Thanks for having me again today. And just to kind of jump right in, to set up today's conversation, we wanted to review some of the literature around today's topic. And we found a few studies that wanted to highlight some of the applications of point-of-care ultrasound, particularly in the urinary tract. This first article that we hit on is a review article, and it highlights how in patients with azotemia, electrolyte, or acid-base abnormalities, focused urinary tract point-of-care ultrasound exams are a useful non-invasive tool for identifying underlying etiologies in a significant number of patients. And then to dive a bit further deep into it, this retrospective review that looked at actual cohort of dogs and cats found that in the retrospective review, while measurements can vary within diagnostic categories, point-of-care ultrasound of the urinary tract identifies with clinical significance pelvic dilatation that can reliably be identified even in patients with normal renal function, and that these findings increase with renal insufficiency, pyelonephritis, or outflow obstruction. And we're pretty soon going to get into the weeds and details on how to do that. But before we do and invite our guests in, we wanted to put up a poll. We know there are providers from across the world at various elements of their application of ultrasound, particularly in the urinary tract. And so how frequently do you do this kind of scan? Do you use ultrasound to assess the urinary tract in your veterinary practice? Is it something new to you today, or something that you've been practicing with some frequency, either monthly or maybe even daily, if you're an internal medicine physician like one of our guests? We'll leave this here for a second and close it out pretty straightforward. And let's see where people are. Oh, great, across the board. And surprisingly, even a fifth of practitioners are using it daily. So we know that you are going to have a lot to learn. And we're so happy to bring back our guests, Serge and Søren. For those of you who have been on prior webinars, we don't really even feel like we need a particular introduction for Søren Boysen, who's professor of faculty of veterinary medicine at University of Calgary, and Dr. Serge Chalhoub, who's also associate professor, faculty of veterinary medicine, University of Calgary. As you'll learn, Søren is emergency and critical care, Serge, internal medicine, the dynamic duo. We're so happy to have them here and their amazing teaching experience. I'm going to hand the show over to you guys.
Hello, everyone. I'm Serge.
And I'm Søren. And once again, we're coming to you remotely from the University of Calgary, here in the beautiful Canadian Rockies of Alberta, Canada.
That's right. Søren, do you know what day it is today?
Today is Tuesday, May 9th?
I think so, but that's not the point. It's kidney day. Whoop, 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 whoop. We're going to talk about the kidneys, point of care ultrasound, whoop, whoop.
So we do point of care all the time. I've never seen you get this excited, but yes, we're going to look at the kidneys, and we're going to actually look more specifically at renal pelvic dilation, among a few other things.
And specifically that we can stop blaming the kidneys all the time, like you love doing, right? It's not always the kidneys.
We'll see if it is the kidneys' fault today. Let's just wait and see what happens with the talk.
All right. So on the menu today, we're going to introduce you to a case. We're going to be talking about Innes and Gunn, two cats that come in. I wonder who named our cats. I'm wondering if we should even pull the audience on that. I think
it's a good name. Nothing wrong with Innes and Gunn. If you've ever been to Scotland, abdominal point of care ultrasound to the rescue. We're going to talk about the different things we can look at in the abdomen. A quick review from some of our other prior podcasts.
That's right. Now we're going to talk about point of care ultrasound and renal pelvic dilation specifically, and how it helps us, especially in cases of azotemia.
And so you get excited about the kidneys, and then we're going to look at something that's really exciting to me, assessing volume status. We're going to look at whether it's okay to give a fluid bolus. Is our patient showing signs consistent with eubulimia to hypovolemia? Yes or no?
Oh, we need to worry about how much fluids we get?
Most of us do. Not all of us, but we should, and most of us do.
All right. Okay. And then we're going to talk about point of care ultrasound and urine volume production, that tracking over time. Are they making urine? Are they not making urine? And why?
And then we'll actually wrap things up. We'll talk about prognosis and how we manage Innes and Gunn right at the end.
That's right.
And in relation to this presentation, we'll just say that we do lecture and give talks at multiple conferences around the world, but otherwise we have no conflicts of interest.
All right. Shall we start talking about those beautiful kidneys? Let's talk about how it's not their fault. Like I know you'd like to blame them. Let's start about point number one, Innes and Gunn, triage. It's 4:59 p.m. Friday evening. I'm about to leave. I want to go home. I want to go out to dinner with my wife, see my child. But no, I become very anxious at this period of time when a case comes in.
So yes, but this is exciting because two cases come in at the same time. They could be unstable. They could be emergencies. This is what we live for. So we get two 4-year-old male neutered domestic short hairs coming in, both gray tabbies, both weighing 4.5 kilograms. And both, interestingly enough, have nice owners named Jill.
I'm sorry, these cats essentially look the same and they have the same named owner, but they're different owners?
Interesting, isn't it?
Yeah, I wonder who wrote this case. Interesting. Okay, well, let's go on a little bit. Wait a minute. They're both lethargic, both not eating and drinking past 72 hours. I'm sorry. This gets you exciting? It's 4:59 on Friday.
It's going to get better. It's going to get better. Both vomited exactly 7 times, not 6, not 8. Both vomited exactly 7 times in the past 24 hours.
And both don't have any prior medical history. Okay, wait. I'm seeing some very strange patterns. Let me guess. They're both indoor-outdoor cats, right? And they're not closely supervised by said Jills.
This is correct.
Interesting. Yeah. I really wonder. I could see why you're getting excited about this. I'm at this point, like, I really have a foot out the door unless someone grabs me and tells me I have to see these two cases.
Well, maybe you should do that physical exam or triage before you walk out the door. Let's actually do appropriate medical management here. And you can see both are sitting at a heart rate of 162. It's not too bad. The average is a little on the low side, 37.4.
I'm sorry, 162 in these two cats coming in stressed and potentially sick. I'm actually worried that's a little low, as well as that temperature.
All right, yes, temperature is low. I agree with you. 62. Okay. All right, it could be really chill cats, or I agree, they could have a bit of depressed cardiac response to white coat syndrome or stress. This is true.
All right. Well, the respiratory rate, that borderline high. I mean, that fits a little more of a stressed out cat or potentially a cat that has any issues. But when we look at the character of respiration, yeah, they're tachypnic, but they're not dyspneic, which is good, and their lungs are clear.
All right, let's do a bit more assessment here. We look at the mucous membranes. They're pale.
Ooh.
Capillary refill time sitting exactly 2 seconds. And decreased pulse quality at the femoral pulses. Now the cases are truly getting interesting. And in addition to what we suspect is poor perfusion, you can see that we have tacky mucous membranes.
Yeah, and we have a prolonged skin tent and sunken eyes. What percentage of dehydration would you say we're in?
All right, I'd say we got hypovolemia and poor perfusion, along with probably an 8 to 10% dehydration. So our patients are looking like they need some volume and some fluids. This is where it's getting exciting.
So I can see you're excited here if I'm using my professional skills, communication skills here, and that you're inferring that these patients are likely unstable.
You're getting angry, but that's good, Serge. Well done. They are unstable. It only took us what? How long have we been working together? 15 years? Good job pulling that one up.
Well, let me do a complete triage exam here. And whoa, I noticed that both these cats have painful paralumbar regions and also very small bladders. That's going to become very important shortly.
All right. Well, they are pretty dehydrated. I
They are
expect them
pretty
to have small
dehydrated.
bladders, but
Yeah.
all right, we'll come back to that. All
Yeah.
right. So what are your thoughts?
My thoughts at this point is I'm leaving. You're in the building, so I'm going to come see you and be like, "Hey, Stern, there's nothing at the door right now. I gotta go." And then as I go, you hear, "Wait a minute, there are 2 cases."
Yes, and I'm going to say, come back because we're going to do some minimum emergency database. That's where we want to start.
All
Patients
right.
are unstable. Let's work them up a bit more. Let's see
Okay.
what that systolic blood pressure is. We're sitting at 80 millimeters of mercury systolic on the Doppler. All right, it's a cat, so a little harder to interpret. We got a oxygen saturation. We knew the lungs sounded okay. They
Yep.
also are oxygenating well.
That's
We
good.
have a sinus rhythm.
Yep.
And then we get the minimum database. Tell me what you think of this,
Well,
my friend.
You know what? I'm looking through this, and yeah, PCV total solids not a big deal, but that azo stick, that measurement of BUN, highest level reading possible on that strip, that means we have azotemia. Now I've actually come back. I was in my car and I heard you say azotemia, and I'm back in the building. I'm actually very excited about this case. And the rest, yeah, probably a stress leukogram here. Lactate potentially fits with poor perfusion, which we were worried about. That.
Stress, poor perfusion, both. Yeah,
Yeah.
agreed. And electrolytes within normal limits, also something that we do want to assess in our azotemic patients.
Okay.
So what are you thinking here?
Azotemia.
All right. And you told me, this is one where I learned from you, my friend. You got 3 main causes: pre-renal, renal, and post-renal causes of azotemia. And if they're unstable, well, then you best come to me.
Yeah, I think that's pretty clear. Yeah, absolutely. Well, if we think about differentials, pre-renal azotemia in cats, we usually talk about dehydration. But for that degree of BUN elevation, honestly, I just don't think it can be all pre-renal. Sure, it might be a component, but I don't think pre-renals are primary category of problems here.
All right. So I agree. The patients are hypovolemic, they're dehydrated. I'm certain there is probably a pre-renal component, but the question remains, is there concurrent renal azotemia? Like you said, it's really, really high. So renal azotemia, indoor, outdoor cats, maybe they got into lilies. Maybe they got into ethylene glycol.
Yep.
Maybe they have a pyelonephritis.
Correct.
Lots of different primary renal causes of azotemia could be dealing with.
That's right. But then if we think about the title of this presentation, it's not always the kidney's fault. And that is absolutely correct. We have post-renal azotemia. The most common causes forgotten. We're talking about ureteral lifts here. Ureteral lifts.
He's got small bladder.
Yep. You're thinking about a blockage to the urethra, Dr. Boysen, not the ureters. What about the ureters here? Absolutely could give you a small
everything
bladder.
after the kidneys, post-renal, ureteral, and urethral.
Correct.
Not like urethral because it's a small bladder, but still
Correct.
could be ureteral. Don't overlook it.
I love it.
All right, I'm
You're
with you.
getting the hang of
Yeah,
it now.
yeah,
Like
yeah.
you tell me, Okay.
I'm with you.
So, okay, great. So we agree that it's most likely renal or post-renal in this case, right? And so I don't know, what should we do next? Do you think running away is actually fair? Should I spend 6 hours thinking about a whole bunch of different differentials, sitting down, drinking my coffee, taking my time, maybe coming back Monday to these cats?
That's why we work well together. You start doing that and let me deal with things in the short term. So you go off and think about your 100 different differentials and come back. In the meantime, we're going to continue stabilization because our patients are unstable. We decided that. And we're going to do further point of care diagnostics. We want to see if we can figure out the underlying cause. So we're going to do some abdominal point of care ultrasound, and we're going to concentrate on the kidneys, among other things. We'll do urinalysis. Came in for azotemia. We want to check that urine for sure, see what the urine production is, start fluid therapy. And along with that fluid therapy, we're also going to want to assess the cardiovascular system in terms of, are we okay to give a fluid bolus? So a lot of things we can do in the next 10 minutes that will give us a great deal of information to further narrow our differentials and tell us where we want to go.
That's right. And for that, then if we hospitalize those patients, we can track to see what the urine production is to know if our fluids are helping or potentially detrimental to those patients. That's going to be very important. All right. So I like that approach. And you know what? No kidding there, right? We're talking about point 2 here. How can we help ourselves narrow those differentials? Again, we've talked about this at previous Clarius webinars. The previous one was rapidly assessing acute abdominal condition using the 5-point abdominal point of care ultrasound exam. We're talking about abdominal POCUS here to the rescue.
Yeah, and in this case, if I think about lots of questions, these are the questions, and go back and review that previous podcast if you want to see some of these other questions in that series. Clarius does have that online for you. But we also want to look at it then from this cat's perspective and think, what are the most likely things in all the questions we can ask and answer at this point in time using a POCUS?
Okay.
So is there free abdominal fluid? These patients are coming in vomiting, dehydrated.
Yep.
Maybe they got a GI perforation or something going on. They are unstable. So we do want to consider whether or not we have free abdominal fluid, or maybe they have a rupture or a trauma to the urinary tract system. So we want to assess for free abdominal fluid for sure.
Okay. Now, question questions that would make me happier in all of this abdominal point of care ultrasound, is there renal pelvic dilation? Yes or no? Because that's going to help me potentially characterize better what's my most likely azotemia. And of course, urine production, yes or no, which we can estimate in millimeters. We're going to talk about that later.
All right. And then just to make me happy, we're also going to look at these unstable patients and assess whether it's okay to give a fluid bolus. So something for everybody in the abdomen.
All right. So let's just refresh everybody's minds here, and especially that we have an awesome cat here with Daisy. Talk to us about abdominal point of care ultrasound. How do we do this in real life?
All right, so we'll go through these. We're going to scan the patient in the position that's most comfortable. Daisy's in left lateral here for demonstration purposes. We start at that subxiphoid. We can palpate that with our thumb, put the probe at that subxiphoid, marker towards the head. There's our liver in the short or in the near field. We see the diaphragm here. Extend the depth beyond the diaphragm so we can see beyond the diaphragm into the pleural space. And then we want to make sure we fan through all planes in long axis. And then we want to rotate into short axis and also fan through all planes to make sure we don't miss any pathology, small pockets of fluid or otherwise. And think about patient positioning and directing that probe gravity-dependent regions.
All right, that's site number one.
Then we go to the umbilical site. So we're going to go straight back. Again, marker towards the head. We just come in at that umbilical site. And again, think about patient positioning where pathology can accumulate. Daisy's in lateral here, so we fan down towards the tabletop, but also away from to make sure we're not missing small pockets that might be caught in the omentum or adhesions. So then we're going to rotate into short axis. And again, we're going to fan through all planes in short axis. Again, thinking about gravity dependence. And if we're looking for fluid, mark that or rotate that probe towards the gravity region.
Number three.
Then we're going to go back to the urinary bladder site. So we're going to go straight back. We hit the urinary bladder. We want to do this in long axis again. And we're going to look at the apex. And don't confuse the colon or gas in the colon for bladder stones. As you see here, you can see white shadowing. But we're fanning through the urinary bladder in long axis, making sure we don't see any fluid or pathology. Rotate again into short axis and fan through that urinary bladder in short axis, looking for any stones, free fluid, pathology. Everything looks good.
All right, number four.
We're in left lateral, or in right lateral, sorry, with Daisy, or left lateral. So we're going to go after that right paralumbar site. So here we got the probe at the right paralumbar site because that's the non-gravity dependent region, really accessible. Look at that lovely kidney in long axis. Perfect. We're going to fan through that, all planes in long axis, like you see here. That's beautifully done. And then again, always do it in long and short axis. We're going to turn into short axis, and again, while we're in transversal short axis, we're going to fan through all planes off both poles of that kidney. No asymmetry, no cysts, no free fluid. Nice view of that non-dependent kidney, paralumbar site.
And then number five.
And we're going to get the other paralumbar site. And when our patients are in lateral, we're just going to allow them to roll into sternal. If they're already in sternal, we'll scan them completely in sternal or standing. But our patient was in lateral, so we roll it up, and we're going to do that that gravity-dependent region. We're going to do the left paralumbar site now. So that's our kidney again in long axis. Again, fan through all planes with the probe in long axis, and turn into short axis, transverse orientation, and just fan through all planes. So again, we've got all five sites. We had our patient in lateral to start with, rolled up, most comfortable position, and scan that non-gravity dependent kidney after getting the other four sites.
All right. So now let's focus specifically on acute azotemia and how abdominal point of care ultrasound can help us. So we've talked about the two paralumbar sites, and what can we ask here? Well, let's refocus on that. Free abdominal fluid, absolutely, in an azotemia case. Free abdominal air, maybe not so much. Renal asymmetry, when you get better and you do scan a lot of kidneys, anyone can look at this and potentially determine, maybe these kidneys don't look quite right. Renal cyst, same thing. Renal pelvic dilation. We're going to focus on that today. Renal lifts, I think that's quite challenging. It's easy to get confused with other things that potentially can shadow in the kidney. So I'm not quite sure that's something. But now, and then we also have the urinary bladder site that can help us with azotemia.
Yeah, for sure. When our patients come in and they're azotemic, we're wondering, do we have free abdominal fluid? We may see that in some of our patients that are azotemic for various different reasons. Again, the free abdominal air, like you said, may be a little less likely in our two patients coming in, but something that we can see at the urinary bladder site. And the big one in our patients that are azotemic, if they're coming in with a small urinary bladder and we're not sure if they're producing urine or not, we'll talk about serial measurement of urinary bladder volume estimation.
Excellent. Oron, I have a quick question for you. In humans, in cats, finding the kidneys is actually pretty easy. They're very superficial. Shelley will talk to us about that later. How easy is it to find the kidneys on point of care in humans?
Usually you just kind of drop the probe on and they pop out if you know where you're looking. Yeah.
Okay, cool. And then other question for you. Do you think this cat is breakdancing?
For sure. Yeah, that's straight
There
up.
we go.
Absolutely.
Ern did draw that. I mean, come on, it looks like the cat's doing this weird.
Cat's in lateral. It's accommodating a point of care ultrasound. I would like to see your illustrations, my friend. I'd love to see you
We
draw
have
a cat or a dog.
We have a renowned emergency physician determining that this cat looks like it's breakdancing, just like you. Look at that.
Definitely.
In fact,
no.
you want to see it again? If you want to see it again. Oh, there it is again.
Okay, let's just move on.
Oh,
Okay,
there it is
move on.
again. Oh,
Move on.
all right. So
Yeah.
now let's come back to those kidneys and what are we looking at? So again, first thing, is there free abdominal fluid at this site? Yes or no? We're fanning to and fro until the kidney disappears in long axis. That's going to be the first thing we do. And then when we've answered that, we want to rotate the probe and ask the same thing. We're going to fan again until the kidney disappears. And that really helps to improve sensitivity for finding free fluid. And then at the same time, we can ask for abdominal air, renal asymmetry, renal cysts. Once we've done that, we can look at renal pelvic dilation. This is tricky here. We're going to talk about the anatomy shortly, but you have to start with short axis. That's the way we measure it. There's other ways to measure renal pelvic dilation. On point of care ultrasound, we look at it in short axis.
Yeah, one of the big things I always look for to tell me I'm getting close to the right plane is that renal sinus. I'm looking for that bright white around the renal crest.
Yeah.
So that we'll come back to that and talk about that in more detail. But the other site we talked about that we can look at is the urinary bladder site, looking again for free fluid, free air, and urine production.
That's right. So now, like we talked about, this is, we tend to cross ourselves. So it tends to be the third site we look at. There's the bladder and long axis. Like Cern said, you got to be careful about the colon because it can mimic systole lifts. So that's why it's important to fan and see that the colon elongates itself. So at this site, is there free abdominal fluid? Yes or no? Don't forget about gravity and how it affects both in long and short axis. The apex of the bladder, the most sensitive site for finding small amounts of effusion in the abdomen. So very important to do. And again, we're going to talk about how we get our measurements.
Yeah, so we want long and short axis measurements, and we're going to come back to that. But that is another important reason we do long and short axis views at all sites. Sometimes you absolutely need both views to answer all the questions we want to.
All right. So now let's talk about that famous renal pelvic assessment in cats. So again, we talked about this. It's going to be in short axis. Run us through the anatomy here.
Yeah, so when you look at the kidney, you can see over here, we've got the cortex, the outer layer, then we've got this medulla, and then that goes into that renal crest that we see here. Often we're going to see that renal sinus to either side. And like I said, I often look for that white renal sinus, that fat in the sinus here.
Yeah.
And it helps me know that I'm getting close to that midline where I'm going to see that renal pelvis. And that renal pelvis really forms sort of this crescent-shaped moon around that crest. So you can see it outlined here in a schematic, and you can envision that here. We've labeled everything. And that would be, in this case, actually, this cat here that we see actually does have a measurable renal pelvis. That is not always the case. A lot of our healthy cats, you will not have any measurable renal pelvis. However, not uncommon, you may see it come up 1 to maybe 3 millimeters in size. If you get to 3.5 millimeters or higher, then you should have a concern for possible underlying concerns or problems. And that includes with fluids. If you're on fluids, we'll come back to that. Your renal pelvic dilation might be a little bit wider, but you still should not exceed 3.5 millimeters in a cat. If I see that, I'm like, maybe there's something going on. We need to consider further workup.
Well, Cern, I think you hit it right on, right? The point is, in normal cats, it's going to be very hard to see that renal pelvis, which means if you don't see it, it's unlikely to be dilated significantly enough to indicate ureteral obstruction. Doesn't eliminate it, believe me, it definitely see it. But our ability to be able to say with certainty that is a ureteral obstruction on the emergency general practice side, right? We need to see that ureteral dilation, right? Unless you're going to see a radiologist who's doing an entire scan looking at the ureter exactly. So that's going to be important. Here we have the anatomy on the right. We can see the crest, we could see the sinus, and that renal pelvis almost not visible there, right?
Exactly. And you probably vision a little bit of the ureter coming in. That's what you do want to see as well. But this is, to me, one of the key things I look for is that brighter white sinus, and then I find the crest and the renal pelvis.
That's right. So a case like this, if this cat was azotemic, I can't say if it's got a ureteral obstruction, yes or no. So that's going to be the way we're going to interpret it. But now let's talk about those studies looking at cats with ureteral obstruction. What do we see here? If can non-specialists image those kidneys?
Yeah, so this is an abstract. This is now in press in the journal of Small Animal Practice. This is by the crew out of the RVC, Dave Beeston and Laura Cole. It is updated, so these are old numbers. This is from their abstract. They've got a larger number of cases. But the important thing I wanted to emphasize here is that this was done by non-specialists. These are cats that came in with azotemia. They had point-of-care ultrasound performed and then formal ultrasound for comparison. And you can see a non-specialist identified that renal pelvic dilation, high lactasia, in 72 out of 100 obstructed cats,
Wow.
versus only 3 out of 40 non-obstructed cats.
Okay.
And some of the other things they look for here are gross renal asymmetries. Like you said, it's something that you can get better at.
Yeah.
Ureteral dilation, they found it in 24 out of 100 cats. So
Wow.
something else that you can see, if you start to see that pelvis, you can often sort of see the ureter start to dilate as well. Right?
Yeah.
And then you can also, like you said, that's harder, but they did find some calculi.
Right. So I think this is fascinating to me, right? Because I think when you look at this paper, cats that had renal pelvic dilation had 39 more times likely to have an actual ureteral obstruction than non-obstructive cases of AKI. So that's interesting. Again, who did this study? Who was the focus group?
These are your non-specialists. They are interns and residents in training, but non-imaging specialists. And therefore, it is encouraging for us. I agree with you. This is one where I would say yes as well. This is something non-specialists can be doing.
Yeah. So I think this is very interesting because, again, it gives us another tool in our tool shed, right? As ER doctors, anyone doing triage, general practitioners, that cat coming in, you're not quite sure what's going on. This is another thing you can look at. So again, like we talked about, a normal renal pelvis, 1 to 3 millimeters. That's normal, not fluids. That's just a cat coming in, right? Now, what's really interesting, again, in point-of-care ultrasound, we like binary questions, right? Binary questions.
Absolutely. And this is one that holds true for cats and dogs. If you find a renal pelvis more than 13 millimeters in diameter, it's consistent with ureteral obstruction.
Correct.
Cats and dogs, nothing else has been reported to give that great a degree of ureteral distension.
That's right. So that's the great tool in the tool shed. You have a cat that's azotemic, renal pelvic dilation greater than 13 millimeters. You've already narrowed the differentials. You can tell that owner this cat likely has ureteral obstruction. Now, the thing is, there's a lot of shade of gray.
Yeah, and if you look at the renal pelvis down here, you can see this one. This is a nice example here from the Journal of Feline Medicine Surgery. Almost has like a Pac-Man appearance to it. You can see the renal pelvis there nicely. You measure that depth there from where the ureter comes in. They cross across that pelvis here. You see the ureter there. That's 6.5 millimeters.
Yeah.
So that's 6.5, 7 millimeters. That's a gray zone. Lots of different things can do that. We can certainly see that with obstruction, but we can also see that with pyelonephritis. We can even see that with chronic kidney disease. We're going to come back to some evidence on that as well. So that's where it gets a bit gray and there is overlap. And I will also add, and we'll talk about this in a little bit as well, absence of significant dilation with obstruction. So we can have cases of obstruction that don't result in significant dilation. And we can see that if a patient comes in extremely dehydrated or hypovolemic, then we're not going to get the same degree of ureteral pelvic dilation, or sorry, renal pelvic dilation.
Yeah.
Just because it's the degree of the obstruction and the degree of urine production that causes that pelvic dilation. So they can be underestimated when they're dehydrated or hypovolemic. And if they're only a partial obstruction or a very early obstruction, then we might not see that same degree of pelvic dilation.
Well, you bring about a very important point. With everything that we do point-of-care ultrasound, something we do is serial evaluations, right? So it looks somewhat obstructed, doesn't meet that criteria. You can't refer them, can't see a radiologist. 6 hours later on IV fluids, whoa, 14 millimeters, there you go. But now let's look at these 3 studies. So we have Quimby et al. Study here, we have Lam et al., and we have Danjou et al., all looking at that dilated renal pelvis or looking at the kidney in general. What are some of the findings we find here?
Yeah, and it's interesting. If you look at normal cats with normal renal function, and we look at those cats with normal renal function, and you can see that median pelvic measurement is only 2.
Yeah.
If you put on fluids, it is true that you will get a slightly larger renal pelvic dilation. So in this case, you see 2.3, but the range on that, they actually don't go over 3.2 and 3.4, even on IV fluids. So in this situation, like I said before, if you have a renal pelvis more than 3.5 millimeters in a cat, it should prompt concern because we don't tend to see that in cats that have normal renal function, even if they're on IV fluids.
Correct. So that's where the 1 to 3 comes in, right? 1 to 3, likely okay, even on IV fluids, 3.5 and above, you should be worried about. So look like it's more findings. So chronic kidney disease in general doesn't lead to a dilated renal pelvis. However, if you look at the range here, right, 0 to 12.5, it is actually possible without a true ureteral obstruction to have pelvic dilation with chronic kidney disease. Why? I don't know. I have no idea, but it's interesting that 2/3 of these cats actually have a measurable renal pelvis dilation, and we don't really know why. So it's important to serially monitor that and try to understand better what's going on with those cats.
Absolutely. And again, if you get a cat and it's sitting at 10 when it comes in and it's got chronic kidney disease, you know that. Then if it comes in with a bit of a crisis later, you're not going to say it's got an obstruction or pyelonephritis per se, because it's had that 10, even though that is rare, it can be documented.
Right.
The other thing in cats with chronic kidney disease, it's pretty rare to see ureteral dilation. So we can see that pelvic dilation and measure that in a lot of them. but we won't see that ureteral dilation. Only 6% have it with chronic kidney disease.
So what about pyelonephritis?
This one I like. This is one that definitely we want to see in the ICU. You can see that the median is definitely much larger at 4 millimeters, but the range on this one, again, 1.7 to 12.4. So we still don't crack that magic 13 millimeter cutoff that we know is consistent with ureteral obstruction.
Yeah.
So gray zone for sure between chronic kidney disease and pyelonephritis with regards to the degree of renal pelvic dilation we can see. But if you also look at our pyelonephritis, 54% of them are going to have ureteral dilation, which we're not going to see with chronic kidney disease. So a bit of a factor there that might help us differentiate a little bit.
Yeah. And then we talk about ureteral obstruction. We can see the range. We can see here 1.2 to 39.1, which we can see that 6.8 as that typical. Again, that 6.8, that's something that I would imagine a radiologist would be comfortable because they'd be looking at the ureter and be like, yep, there's the obstruction. Again, on point of care ultrasound. Binary question, greater than 13 millimeters, azotemic cat, we have ureteral obstruction, yes or no?
That is the magic number. And once again, we do want to emphasize that if it's a partial obstruction, if it's acute, or if our patients are severely hypovolemic or dehydrated, then we may not see significant renal pelvic dilation, even if our patients are experiencing ureteral obstruction.
Yeah. The other thing is in these cases, most of the time that ureter is visible, that proximal ureter is distended. All right. Well, let's come back to our cases. We have gun. And we're going to go ahead and look at those kidneys. And here we go. We're looking at the left kidney. Whoa, I actually see the renal pelvis on this one.
Yeah, that's actually quite a, there's our crest sort of ends right about where our marker is.
Yeah.
And then you see you got quite a distended renal pelvis. And you actually do see a bit of the ureter coming in here, which also looks distended. So this is actually quite impressive with the size of that dilation there. So we got quite a bit of renal pelvic dilation for sure.
That's right. So that's the left kidney. Now let's look at that right kidney. And there we go. We're moving a little more there, but there we go. We're going to get that short axis.
I saw the sinus in the crest there. Wait a second. Oh, there it is. Real quick, went through it. Come back.
Not very visible there.
Yeah, there we go. Frozen.
Okay, so hold on a second. So left kidney ureteral dilation, right kidney not. You know what? Already that smells to me like a potential obstruction. But let's go ahead and measurement. When we actually measurement, if we do
look at that, we can fit a whole Chalhoub head in that renal pelvis. And look at that. You even put a little mark of yourselves on the side there. That's 10 millimeters from your forehead to your chin there. That's what's 10.1 millimeters. That was very helpful. Just imagine how many of your heads you can fit in there. That will help our attendees estimate the size of that renal pelvis.
Where did you get this image? Did you ask for trademark permission? That might be infringement. I'm sorry. I'm not happy with this.
So this one's 10.1 millimeters. It is very big. You should be thinking ureteral obstruction, ureteral obstruction, ureteral obstruction. But like we said, you can get chronic kidney disease. Doesn't really fit in these cases, or pyelonephritis that might do that. So 10.1, we're definitely leaning that direction, but we can't say definitively.
We need more information.
It's not over 13, so it's not black and white.
Yeah, we need more information, and this is also before fluids, right? So now let's look at NS. There we go. We're going to start at the right kidney. Oh, there's pelvic dilation there. We can see that. We're going to get some measurements. There's the right side, and we can get the left side as well. Okay, so there's bilateral renal pelvic dilation in short axis. Let's go again, some measurements, and whoa, okay.
Definitely in the gray zone here. Yeah. We got this bilaterally sitting at ranges that we could see with ureteral obstruction or with pyelonephritis. Maybe we could get this with chronic kidney disease as well, but again, doesn't fit. So now I'm wondering, ureteral obstruction, pyelonephritis, what are we dealing with?
Well, it's bilateral. It's interesting. Bilateral ureteral obstruction definitely happen, but I think for both cats, we need more information.
All right. And we talked about doing an urine analysis. That makes perfect sense. These patients are azotemic. Here you can see on the left, we've got NS. Ooh, that is a cloudy urine sample. Yeah. Look at that. You can't see through that at all. And if we spin it down, it's post-centrifugation. Look at that. We got a little pellet down there at the bottom of that. Ooh, now I'm thinking this is a pretty active looking sediment. We're going to have to do more with this. This is exciting.
And then you can see gun, that urine's pretty transparent, right? And there's not much of a pellet. So potentially we're less worried about, an active sediment. But let's go ahead and look at the actual urinalysis. Let's go ahead and hone in on the big one. So for sure enough, NS, you could see significant white blood cells in there. So very active sediment versus gun, not so much. And also NS has some rods in there. We can see the pH difference as well, which is important. And then of course the rods we can see for NS. So again, for NS, it's starting to smell a little more like potentially pyelonephritis.
You see those active urine sediment with bacteria. I'm definitely leaning towards pyelonephritis to cause the signs that we're seeing. I'm not so sure with gun. It looks to me like it's pretty inactive. So I'm thinking maybe more of a possible ureteral obstruction. need more diagnostics. But let's go ahead and look at our unstains. My wife's a clinical pathologist, veterinary clinical pathologist. She would shoot me if she said, don't get an unstained wet mount to look for crystals in addition to a direct smear stain with Diffquick. See that on the left? We can see active sediment in the unstained mount. And then we actually stain that, come down. You see it on low power. It looks like lots of white cells and bacteria. If we come in on high power, look at that clump of bacteria. And the most exciting thing, always gets a critic that's excited, intracellular bacteria. That is beautiful when we see it. We know that that's real. That is intracellular. So we're dealing with an active infection here.
Yeah. And then for gun, whole lot of nothing. And then direct smear, whole lot of nothing. So again, potentially supporting. But you know what? We're not done here. So sure, Innis, we're starting to get the theory here that we probably have pyelonephritis. It would make sense with everything.
Yep.
But gun, again, we didn't reach that magic 13. And you know what? We're potentially 24, 36 hours from referral. So why don't we do another diagnostic test? What can we do?
And we can do abdominal radiographs for sure. The two are complementary. And in this case here, you can see that ureteral stone right there. This is a lovely stone that you can see in the uterus here. Right mid-abdomen on the radiographs. You could have gone for a formal ultrasound. There's a good chance that a very experienced imaging specialist could pick up that stone in that ureter, but they're not always available. So in this case, radiographs were beautifully complementary. Gives us the answer. We know what we're dealing with a ureteral stone now.
Yes, it is important to note that the literature says, though, that ureteral lifts are actually it's not very sensitive on radiographs to detect them. So we were lucky here, right? So if you do see it, and if it's a renal pelvic dilation, chances are that's what you have, right? So, but now let's talk about IV fluids. Do these two cats need IV fluids? Yes or no?
Based on their clinical presentation, you bet. They got GI losses. They're vomiting. They got decreased intake. We already said they're dehydrated, and they probably got ongoing losses through the kidneys up to this point in time. So yes, absolutely. And the goal then, if we have evidence of hypovolemia, and we have that clinically, we're thinking bolus IV fluid therapy. Our patients are 8 to 10% dehydrated. They need a good clip of fluids to replace that. Then they need to think about maintenance and ongoing losses. So absolutely, fluids are essential in these patients.
Hold on, I got to ask you something. That dog strangely looks like Cypress, one of my two dogs. Why in the world did you put that dog trying to go away from that overfilling bath?
We'll come back to this because you don't want to drown them. You got to balance the need for fluids against the detriment of too much fluids. You need that anti-Chalhoubism to prevent you from going into too much fluids. I know you love the fluids. I know you love giving the kidneys fluids, but there is such a thing as too much fluids, and we want to avoid that.
Hold on. We're talking about the kidneys, correct?
Yeah, you bet we are.
And the kidneys love fluids. So what's the problem here?
Yeah, the lungs, the other organs don't necessarily love the fluids as much as the kidneys.
That's not my problem.
And if the kidneys aren't eliminating the fluids, you're going to cause a problem.
I also want to point out, again, going to trademark, you misspelled my name there. So that's another infringement thing I want to talk about later that you're going to be in trouble about. All right, well, we're talking about point of care ultrasound here. How could it help us determine if that patient is hypolimic? Like previously, we just put our hand on the patient. Now you're telling me we can use ultrasound?
That's exactly what I'm saying. So finally, we're getting off the kidneys into something exciting. We're looking at the vascular system and the cardiac system. We're going to look at these to help guide our decision. Does point of care ultrasound support a fluid bolus? Yes or no?
How do we do it?
So we're going to look at the caudal vena cava, and then we're going to look at the heart. So we can look for pseudohypertrophy in the heart, and we can look for a flat or a massively collapsing vena cava to suggest they're hypovolemic.
All right.
But again, it's a holistic approach. Consider your clinical findings, your other diagnostics, and make sure everything fits.
Well, first of all, let's recap how we find that caudal vena cava. So you need to palpate that subxiphoid region. We're going to start with the probe in long axis. You could see there, and boom, if you fan to the right, more toward the gallbladder, you could see that split in the diaphragm. That is the caudal vena cava. So we could see the proximal wall, distal wall. Don't look beyond that because that's all a reversion artifact. And we can see a change in diameter in that caudal vena cava. We're going to talk about the importance of that change in diameter. And you want to examine the caudal vena cava through its entire length, not just at the entrance of the diaphragm.
Exactly, because over here it doesn't change much out here beyond the diaphragm. Biggest change is going to be in the area of the abdomen. So we want to check more in the proximal regions of the abdomen.
All right.
And what's normal? You can see that we have the image up here. We've got the diaphragm crossing the liver. There's our near wall. There's our far wall. Beautiful image of the caudal vena cava. Down here, we got the liver. We got the diaphragm. This is the stomach here with a bit of fluid in it. Don't confuse that for the gallbladder. Down here, two things I'm going to look for in our patients when we assess the caudal vena cava. How much does the actual vena cava change in diameter between inspiration and expiration? We want to see in cats at least a 20% change.
At least.
They have a much less change than a lot of other species, but this is what we're looking for in our healthy cats, at least a 20%.
And that's a dog.
This is a dog
Yeah.
that you're looking at here, yes, but we will show a cat in a second. But we're looking for this degree of change between inspiration and expiration. And we're also looking for, although it's less consistent in cats as well, we're looking for that cardiac pulse. So I can see that heartbeat radiating back here. So I see a heartbeat, which is normal, and I see at least a 20% change in our feline patients. Then we're probably at least euvolemic towards hypovolemic.
So hold on. Am I trying? That sounds very internal medicine. Am I trying to label this patient? Oh, I think it's hypovolemic, euvolemic, or is there something that it can do treatment wise here?
Yeah. So in theory, we're looking at a euvolemic patient like you see up here. Take a deep breath. When you breathe in, you get negative flow pressure. It draws fluid from the abdomen, and you get smaller on okay, go ahead and breathe.
Oh.
Vena cava gets smaller on inspiration, so that change should be at least 20%. And when your hypovolemic is flat to start with and often fully collapses. But the reality is, if you look at the research, there's a huge overlap between euvolemia and hypovolemia. There's a huge gray zone in there. So you can't usually differentiate euvolemic from hypovolemic, but the reality is, I don't care.
No.
My patient comes in and I assess him as needing fluids on my clinical evaluation, and I see signs of either euvolemia or hypovolemia on my ultrasound. That means that patient's likely okay to receive a fluid bolus, and it's unlikely to cause harm. So most of our euvolemic patients, if they're not contraindicated to get fluids for some other reason, are going to be able to take that fluid bolus fine. So to me, it's okay to give fluids, yes or no. Difficult to differentiate euvolemic from hypovolemic.
Yeah, and the answer no is when you see that cauda vena cava and it's fat, it's distended, you lose that cardiac pulse. There's not a 20% change, it's maybe 5 or no change. Then you're worried about that patient, and you should probably hold on giving fluids. Try to determine why that cauda vena cava is so distended, right? Because fluids can be detrimental. So we have an actual case here.
Yeah, so this is a cat. So again, we wanted to show you specifically a cat and some of the degree of change in that vena cava. This is a cat that came in diabetic ketoacidosis. It was flat. Hypovolemic, it got fluids, it actually got plasma as well. But you can see when it first came in, this vena cava is almost non-existent. You can see the reverberation here, but look at it, it's pulsing and almost collapsed completely. This is a patient that needs fluids. Unfortunately, they were a little aggressive on the fluids. He got plasma, he got a lot of fluids, and you can see after that large fluid administration that this cat's vena cava has become quite distended with minimal pulse and minimal change on inspiration and expiration. So we did put him into volume overload in this case. We gave him furosemide, and you can see now we're starting to get a change with our inspiration expiration again. So just a nice example to give you a baseline on flat versus fat in our feline patients when they are assessing the vena cava.
This is great. I like this. So again, we get our initial baseline. And like we said, we're going to do serial interpretation, point-of-care ultrasound. And we can see both for Innes and Gunn, these cauda vena cavas are definitely not fat. I think that's the way I'm interpreting. They're not fat. And again, we're going to assess other things, but I'm likely safe to give a fluid bolus to these patients.
Yeah, this one here, it's collapsing nicely. This was this one. Both of these are suggestive of, let's go ahead and give them a fluid bolus.
All right. Okay. So I like that. So we can give fluid bolus, like you said, but we need a little more information to potentially support that these patients are hypovolemic. I mean, we know that clinically, but why not also add point-of-care ultrasound to that assessment?
Yeah. So the nice thing here is when it comes to volume status, it can be challenging. So we look at multiple parameters.
Yeah.
Let's also look at the heart and see if that supports a hypovolemic state. So we can look at the heart. The two things we're looking for when it comes to assessing hypovolemia: the left atrium, is it deflated less than or equal to 1-to-1 with the aorta? And is the ventricular lumen small with thick walls at that mushroom view? Now, again, go back and look at our prior Clarius sessions. We did do a veterinary point-of-care ultrasound differentiating primary cardiac from pulmonary and pleural space disease, where we actually walk all the way through mushrooms, fish mouths, Mercedes, whales, all kinds of different signs that you can see when you're looking at the heart. So go back and review that. What we really want to focus, though, for volume status is what's that left aortic ratio, what's that ventricular lumen and wall thickness just below the mitral valve.
I saw Oron chuckle there. I think he remembers the fish mouth as blah, 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 blah.
Yeah, it's written right there. If it's written on the slide, then it's got to mean something.
It's got to be scientific. So yeah, I'm sure he uses that in humans too, right? I mean, he's scanning humans.
I hope he doesn't. I really hope he doesn't.
Yeah. All right. So so explain this to me a little bit. So we have a normal heart on the left here. Okay. We could see nice change systole, diastole. What happens when you take volume out of an organ like the heart?
Yeah, it's just like urinary bladder. Most people are accustomed to taking fluid out of the urinary bladder. The lumen gets small, the walls get thick because it's an elastic structure. The heart's also an elastic structure. Take fluids out, the lumen gets small, the wall gets thick. We get pseudohypertrophy. It's actually it's been documented in every species that's been studied: humans, pigs, dogs, horses, cats. This happens to be a dog here, but the concept is exactly the same. small lumen, thick walls.
Well, hold on, Cern. I'm looking at that cat and I'm just starting to do my heart scan. I'm sweeping up and down the heart and I'm at this mushroom view. I'm like, whoa, this cat looks like it has hypertrophic cardiomyopathy. I'm not a cardiologist, but I'm worried about that.
Now, again, go back and review that talk we did previously. But if this was a hypertrophic cardiomyopathy, that left atrium should be enlarged.
Yes.
And the kicker here, if it looks like a pseudohypertrophy and that left atrium is deflated, it is equal to or less than the aorta, like you see on the right here, that would tell you that even if this is a cat, this is going to be pseudohypertrophy. We got volume depletion.
That's right. And here's the study that supports this. Campbell and Kittleson, Journal of Medicine, Veterinary Internal Medicine, 2007. What do we got?
So you look at the normal, you can see that the mushroom view, you see a nice mushroom here, normal, and you see the lumen get small and the walls get thick. Same thing here. Left atrium is nice. It's greater than 1 to 1. It's probably 1.2, 1.3 in this patient. Gets down to 1 to 1 or less. And here are the actual numbers. If you look at diastole and systole for the left ventricular internal diameter, we went from baseline at 13 to 9, 6 to 4. Same thing, the left atrium 1.4 to 1.2. All statistically different when we get hypovolemia.
Okay, so let's come back to Innes and Gunn. Let's say I have signs on the heart of pseudohypertrophy, right, of hypovolemia. I have flat cauda vena cavas, or at least normal cauda vena cavas. Am I ready to give IV fluids, or should I look at one more thing?
So another thing we can look at, we can make sure we don't have any contraindication to giving fluid. So I want to look at that lung surface. Again, we've done this talk as well. So here you can see it, veterinary point of care ultrasound, differentiating primary cardiac from pulmonary pleural space disease. And we also talked about veterinary point of care ultrasound, pleural space and lung for everyday practice. Talks a lot about B lines and things that we look for and that can cause that. But the bottom line is look at the lung surface. If you don't see any B lines, you don't see any pleural effusion, you have no pleural space and lung contraindications to fluid therapy. We want to check that before we give the fluids. In this case, look good with Innes and Gunn. We have no reason not to give fluids.
All right. So flat cauda vena cavas, we don't have any B lines. We're doing pretty good. We have pseudohypertrophy. Now, last point here, cats, these two cats, are they producing urine? We start fluids, right? How can we track that over time?
Yeah, so this is where we do that serial bladder measurement. And you can see, again, another talk, go back and look at rapidly assessing acute abdominal conditions if you want to see these in more detail. Nice study that came out. Bottom line is you need short axis and long axis, width, length, the average depth times 0.52 to get an answer in milliliters.
That's right. Now, before you start talking about oligo or anuria, it's important to correct for hypotension, hypovolemia. It's important to correct for perfusion issues, dehydration.
Yep.
Once those things are corrected, then you look at that urine production to determine if that patient is oliguric or anuria.
100% agree. So you can see that both our patients received bolus fluid therapy for hypovolemia due to the evidence that we had. Then we started them on a continuous rate infusion of IV fluids for the dehydration and other ongoing losses, etc. And then we're not going to go through the calculations, but we wrote them here if you want to double check them. The bottom line is when we look at Innes and we look at Gunn, we do those calculations over a 4-hour period, 0.14 mil per kg per hour for Innes, 3.4 mil per kg per hour for Gunn. What do you think of that?
Well, I'm worried Innes is oliguric at this point, and that's concerning. Again, I'm going to go back and check hydration, blood pressure, etc. But if that's really what his urine production is, that's under the magic 1 mil per kg per hour. I'm very concerned. Gunn, that's pretty good, 3.4. I'd like it to be higher, actually. So I'm going to keep serially monitoring. But I am quite worried about Innes and his ability to make urine and what that's going to do for him in general.
All right. So let's come back and summarize Innes and Gunn then. Innes, we believe, has pyelonephritis. Why? We had an active sediment.
Yeah, that's right. Gunn had an inactive sediment, and we think he has a ureteral obstruction based on that left-sided pelvic dilation of 10.1. Now, in itself, that wasn't enough to say binary question, yes or no, ureteral obstruction. Now, Innes, a bit different.
Yeah, in this case, we had renal pelvic dilation that was in that 5 to 7 gray range, a few different things that can do it. And it was bilateral. So this is where we had to actually look at that active sediment and say, yes, I see bacteria. They are intracellular. This is active. And we have white cells in the urine as well. So now we're dealing with what is enough for us to say we have a pyelonephritis in Innes. Let's go ahead and make sure we start therapy for that.
Correct. Versus Gunn, we did abdominal radiographs. And in our case, helped us confirm that we did have a ureteral lift, certainly fits. And then we wanted to put these animals on fluids. We determined that they were both hypovolemic based on looking at the heart, cauda vena cava. And then what do we do?
And then we also looked at the abdomen in our POCUS exam, no abdominal effusion. We looked at the pleural space and lungs, no indications not to give fluids or no contraindication to fluids. So we started fluids. And in the case of Innes, we started antibiotics.
Yeah, and we were worried about oliguria based on that urine production on serial monitoring. And then versus Gunn, we started fluids, good urine output, And we went ahead and placed a subcutaneous renal bypass, not immediately. I think it was about a day after. And he did get a full radiology consultative ultrasound, which confirmed the obstruction, etc.
And how did Gunn do in the longer term?
Gunn actually did great.
All right. And same thing with Innes. Innes had a culture sensitivity. It was E. coli, responded beautifully to our antibiotic therapy and fluid therapy. Did start to urinate 36 hours later. Beautifully, did well, went home.
That's fantastic. Well, that brings us to the very last slide. Let's talk about prognosis. The general prognosis for acute kidney injury, acute azotemia is roughly 50-50 when we look at a couple of the studies out there. Now, we know that in general, which what that means, by the way, is half made it, half don't, and the half that do make it are left with chronic kidney disease. However, we know that pyelonephritis is a better prognosis. Actually, ureteral obstructions, when targeted early, with potentially subcutaneous renal bypass, actually have a pretty decent prognosis. However, what will affect prognosis?
And the biggest thing, you can see the difference here. The median survival time was 1,072 days without fluid overload. And this is a huge kicker. 70 to 80 days with fluid overload. So it wasn't the azotemia.
No.
It wasn't the potassium.
No.
It was the actual fluid overload that had the greatest influence on prognosis. So it's really important you don't fluid overload these guys. Fortunately, we had all the ability to monitor things serially with point-of-care ultrasound. We avoided that in Innes and Gunn.
That's right. Those subpapers, and potentially we'll come back to that some other time, certainly indicate the value in not overloading them with fluid. So in summary, point-of-care ultrasound, abdominal, very helpful in assessing cats with acute azotemia, AKI. Talked about pre-renal, renal, post-renal causes, and non-specialists can look at that renal pelvis.
Yeah, and then that serial POCUS exam, very, very important to look for urine volume production non-invasively. Something we definitely do with point-of-care ultrasound.
That's right. And cardiac and vascular point-of-care ultrasound helps us identify hypovolemia.
And then we want to make sure we have a baseline systemic point-of-care ultrasound. It provides guidelines for fluid monitoring and development of any in-hospital complications. So we didn't really cover the complications specifically, but that is something that we would want to do for sure. Get that baseline and follow it seriously to make sure we don't.
And the most important point here, Dr. Boysen, is internal medicine is a medical discipline primarily concerned with evaluating, diagnosing, and treating whatever it was that upset the kidneys. You know what tends to upset the kidneys?
Pretty much everything.
The heart.
Pretty much
the heart.
Everything. Your kidneys are a high maintenance organ. They take a lot of blood flow from the heart. So just about everything upsets the kidneys.
It's the heart.
But on that note, we will finish and take any questions.
Merci beaucoup.
Thanks, guys, so much for that enlightening and animated conversation where kidneys are really in the forefront of everybody's mind now. Thanks. Please keep using the Q&A tab down below. We will get to as many questions as we can. We'll probably go a little bit over the hour, so stick with us for maybe an extra 5 minutes so we can get through as many of these questions as we can. Before we get there, we're going to hand it over to Shelly Gunther, our clinical marketing manager, for a quick demo.
Great, thanks guys. I'm going to just switch over my camera here. We got our 18-year-old cat Mugen here, who's volunteered, and he's such a good boy. And we'll do a really quick study, and you're gonna watch Shelly flail and try to find the kidney on this guy. So good. So I'm just going to part the fur here as recommended and try to kind of feel for the bottom of the ribs here. And then I'm just gonna set the scanner down and we'll see what we can find. All right, so I'm using the C7 scanner and the abdominal preset. Okay.
And you're looking at the left kidney there. So it should be right behind that 13th rib and usually a bit higher than you think.
Yeah. Let me just have a better look here. You get a bit squirrely. Yeah, there we go.
I think we saw it. There it is.
Oh, there it is.
There it is.
All right. Good.
That lovely kidney and long axis.
So we're seeing the kidney here and long axis. Yeah. Great.
Nicely done.
Awesome. So I'm just going to fan through that kidney. Just look for any abnormalities. That's a pretty good looking kidney for 18.
Love
hey?
that kidney.
I agree. For an 18-year-old cat,
Oh,
that's a good kidney.
Mom just said he's older than that. Yeah. And then I've turned the scanner 90 degrees and I'm just fanning from upper
There it is.
to lower pole. And
I saw the renal pelvis. I mean, there was no renal pelvis visible. But
or what?
Saw the renal crack. So nice symmetry, no cysts, and yeah, there's
there
that sinus coming in where you see that bright fat. There's the crest.
Yep.
And
Awesome.
no real visible black separating the crest from the sinus. There we go. Beautiful image.
Nicely
Excellent.
done.
No evidence of
Great.
renal pelvic dilation. I'm giving that a thumbs up on healthy kidneys to our volunteer for the day.
I'm giving him 2 thumbs.
Excellent. He's pawing at me. He's trying to claw me here. So I think he's done.
But that was
Great.
excellent because cats can be challenging. It was nice to see that scan.
Yes. Yeah. And I love that your advice about, scanning them in the position that they're comfortable, and it just makes so much difference.
Great. Thanks so much, Shelley. Keep the QA is kind of blowing up down here, so we will get to as many questions as we can. Before we do, I'm going to hand it over to Janez.
Yes, thank you. A friendly reminder to stay with us for at least 15 minutes to qualify for 1 CE CPD credit. And thank you, Dr. Frankel, Shelley, and Drs. Boysen and Chalhoub for a phenomenal session. Looking forward to the Q&A. Before we start our live Q&A, we hope all of you who've joined us today will stay for the top of the hour so that we have an opportunity to answer all of your questions. In the meantime, I'd like to invite you to learn more about Claris by completing a poll here. Claris is available in over 90 countries. Pricing and availability does vary by region, so feel free to request a quote and pricing. You may opt to speak to one of our experts about the advantages of wireless ultrasound. If you'd like to discuss scanner features, please select that option. You can also book a virtual one-on-one demo with our experts to see the new Claris HD3 in action, and we can send you more video tutorials for veterinary medicine. So please go ahead and select as many options as you wish. While you take a minute to participate in this poll, I would like to tell you about Claris Vet HD3 scanners for the highest definition wireless ultrasound imaging to speed diagnosis for small, medium, and large animals. Our C7 HD3 microconvex vet scanner, which you saw in action today, is specifically designed for clear imaging for small and medium animals like cats and dogs. We also have the C3 convex vet for larger animals like sheep and horses, and the L7 linear vet for superior animal MSK imaging, often used in equine applications. Now, 30% smaller, lighter, more affordable with an enclosed battery, our 3rd generation family of vet scanners are unrivaled for high resolution imaging in handheld ultrasound with dedicated animal presets. Claris shows you the fine details you need to investigate an area of concern, perform a fast exam, and make a confident diagnosis on your patient's first visit to expedite the right treatment plan. Each scanner is designed with not 1, but 8 beamformers, 192 elements, and artificial intelligence that together deliver the image quality and speed only found in traditional systems, but at a fraction of the cost, representing 85% savings. AI replaces complex knobs and buttons to optimize imaging and streamline workflows, making our scanners fast and easy to learn and use. Claris is also wireless with 0 footprint for high portability to scan animals where they are, from the vet clinic to their homes. You get free movement with no wires getting in the way or startling the animals, also making it so much faster to clean and disinfect. Only Claris delivers wireless scanners with an ecosystem that includes a free app for your iOS or Android devices with free updates. Available with our new membership, Claris Cloud is available to save and manage unlimited exams and create reports anywhere. Your membership includes in-app Claris classroom videos with experts like Drs. Chalhoub and Boysen, as well as onboarding with a Claris clinician to build your ultrasound scanning skills. Claris Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. And with your membership, you get exclusive access to the popular Advanced Veterinary package, which offers more flexibility with additional tools and advanced workflows for various animal examinations. For example, with finely tuned presets categorized by anatomy, more comprehensive measurements, needle enhanced for procedure guidance, and the new OB growth tables for both dogs and cats to obtain more accurate estimation of gestational age and fetal growth. With increased billings, you'll see a rapid return on your Claris HD3 vet scanner, which is ultra affordable. We'll now close out the poll in 3, 2, 1. Thank you for participating. We will get back to you in the coming week. I'd like to now begin our live Q&A session. Please use the Q&A icon in the menu bar to ask your questions with Drs. Boysen and Chalhoub as they join us. Because it's a common question, I do want to let everyone know that in the coming days, we'll send you an email with the recording for today's webinar. And you'll also receive a link from the Vet Show to redeem your CE CPD credit if you participate for 50 minutes or more. I'd like to welcome back Dr. Frankel to moderate our Q&A session.
Great. Thanks to everyone for sticking around. I think we'll extend it for about 5 minutes here and get to as many questions as we can. First question always comes up in all of the webinars. What's up with the shaving, not shaving? How do you scan?
Yeah, we don't shave.
Okay.
We rarely shave, actually. If you part the fur so that you can put alcohol right on the skin, that's going to give you actually a pretty darn good contact. And again, we're not doing this as consultative full abdominal ultrasound, right? We're using this as an extension of us, the clinician, and usually during a triage situation.
Yeah, it's a focal window, and therefore that's why we get away with it. Because if you think about it, the goal of clipping is to remove the fur to prevent air from getting trapped. If you separate the fur and can see the skin, you're going to get a similar effect. So it's just a matter of parting the fur. And as Sir says, because we're not scanning the entire abdomen, just focal areas within it, we can get away with just parting the fur and not shaving.
Right. And
Great.
actually, Oren, on emergency in humans, do you shave each site that you look at for?
we specialize in hairless apes. That's what we scan. That's the species we scan. So it's not so much of a problem. Okay, how about kidney cysts? That's something we deal with in the human population all the time. We see renal cysts as probably our biggest incidentaloma that we see on point of care ultrasound. Is that something you guys encounter in the vet world? And if so, what do you do with it?
We do. I think that the point about renal cysts is that then we're starting to cross over into probably more consultative ultrasound and things that I do in internal medicine. So I think it's great when we can identify them on, point of care ultrasound. I'm not going to start making treatment or decisions or full interpretations about it. It might be something that I want refer maybe just to make sure it's truly a renal cyst and not something like something more serious.
And we do get polycystic
Exactly.
kidney disease that is going to result in renal failure. So knowing when that cyst is benign and when it might be pathologic. So I think it's definitely something we look for. If we see it on our point of care evaluation, then we should say that, yeah, this is something we found. They may want to consider consulting a specialist at that point.
How about a flip side, another incidentaloma being like if you find stones, renal lifts, without any clinical signs or problems with the urine, is that just considered incidental finding, or do you have to chase that one?
Well, that's a good question. I think if you do see nephrolifts, you should first of all make sure that they are nephrolifts. It's actually it can get confusing sometimes that some of the normal structures of the kidneys will actually create certain shadows that people may mistake as nephrolifts. So that's number one. Number two, when you see nephrolifts, there's really one paper that says that there's no quote unquote clinical significance for that kidney. In other words, there's no treatment modality that you can do. I don't know how much I agree with that. I think you still need your full blood work. If that cat has potentially idiopathic hypercalcemia, another condition causing high calcium, well, maybe you should worry about some kind of treatment to help prevent those nephrolifts from forming. But I guess the paper essentially said for the kidney itself, there's really not much to do when there's a nephrolift, unless it's an obstructing pelvic nephrolift. But most nephrolifts tend to be in the parenchyma of the kidneys, which you can't do much, again, unless there is a reason that you discovered and in the blood, for instance, or other medical conditions.
Yeah, most of the ureteroliths we see as well, we didn't mention that, but they are calcium oxalate in origin.
Yeah, that's right.
Okay, great. So maybe one or two last questions. I know you talked about combining it with cardiac scanning. Do you integrate pulmonary scanning too when you're assessing for kind of fluid status in your renal patients?
So absolutely we do, for sure. We will scan to make sure we don't have evidence of B-lines or lung surface pathology when we start scanning. And then we're going to follow that serially. Most of that work's done as an extrapolation from the human literature with the Falls protocol, fluid assessment and lung evaluation by Lichtenstein and colleagues. So we do follow it. And if we put our patient on fluids, again, we believe that one of the most sensitive indicators that we're going into fluid overload is the development of B-lines while a patient's on fluids that wasn't there previously. So we'd be happy to come back and give a more specific talk in our veterinary patients, cats and dogs, when it comes to monitoring serially the development of fluid overload, because lots of different things we can look for, and changes in the heart, changes in the vena cava, changes in the lung itself, and also changes in gallbladder wall thickness. Lots of different things we can look for, and we do look for when it comes to serial evaluation of patients on fluid therapy for development of Chalhoubism or fluid overload.
Great. Maybe last question here. When you have patients with pyelonephritis, like in the human world, it's a finding where things become more echogenic as they're inflamed. Is that something, we didn't really talk about that much, but is that something that you guys see also?
You can see that. There's no doubt, especially in the renal pelvis, you might see some things, in the urine also. But again, would I take that, and be like, oh yeah, that's pyelonephritis because that urine looks cloudy on ultrasound? Absolutely not. If I'm a radiologist, again, with years and years and years and years of training, maybe I'll feel more confident saying that. But the reality, again, that might be just more an extra thing that I'll know.
Yeah, because the sensitivity, specificity are not that great. And we can also see like perirenal fluid, or we can see bright fat around the kidneys sometimes with that as well. But again, it's not specific and it's not that sensitive. So something we'll make note of it, but not something I would, again, like Serge said, hang my hat on.
Yeah.
Yeah, I think that's similar to how we approach it, that it's not dichotomous enough. Echogenicity is more of a scale, and stay away from the scales.
Yeah.
Great.
Exactly.
Well, appreciate everyone sticking around for an extra few minutes. If we didn't get to your questions, we will be following up in the short term to try and get to them. And Janez, I'm going to hand it over to you to close us out.
Yeah, thank you. We did get dozens of questions, so we will get back to you if we didn't address your question in the session today. Please do complete our closing survey, which gives us your feedback so that we can continue to bring you great educational content like today. You will receive a copy of the recording by email in the coming week, so please keep an eye out for that. I'd like to conclude by thanking Drs. Boysen and Chalhoub, and also thanking Dr. Frankel, Shelley, and all of our furry supporting characters. And of course, thank you to all of you for joining us here today. I hope you had as much fun as we did. Bye-bye.
Thanks. Bye, everybody.